Actress Jennie Jacques uncovers Lyme with Professor Jack Lambert. Before we begin, I have a confession. Forgive me, Father, for Judith has sinned. I did not get dressed for this interview because I'm still recovering from an ME crash at the milder end, but I'm still on antibiotics, also for ongoing infections. So I've decided to own the bad look, inclusive of the curry sauce stain on my tiger pajamas.
Lyme disease was first described in old Lyme, Connecticut in America. That's why it's called Lyme disease. There's a town the other side of Connecticut. So it's spelled Lyme, Lyme disease. And it's a bacteria. Lyme is a bacteria that you get from a tick bite. It was first described in 1975 because there was an outbreak of all these kids that were getting in a small community in Lyme, Connecticut, a wooded area. They were getting this juvenile rheumatoid arthritis. So they were sick with this mystery illness. And it was very unusual to have so many cases of juvenile rheumatoid arthritis in a small village like that. And then the American CDC went out and investigated, and they actually found a bacteria in the blood of these kids. And then they later identified that bacteria as Borrelia burgdorferi, which is the bacteria of Lyme disease. Ticks are tiny little insects, the size of a sesame seed. And ticks are everywhere, but people aren't aware of that. So, for example, if you go to Bushy Park in London, there's ticks in the grass there. If you go to Twickenham Park, there's ticks in the grass there. And some of those ticks are carrying this bacteria. So you walk in the grass, the tick jumps on you and bites you. And it's not like an insect bite. It's not like a sting. You don't feel the bite. And then if you're unlucky enough, and that tick happens to be carrying Borrelia, the Lyme bacteria, gets into your body, gets into your system, you may get a flu-like illness, you may get a rash, you may get joint pain, you may get brain symptoms, And then most time people don't remember the rash, people don't remember the tick bite. And in the UK, doctors and specialists think Lyme disease is very rare. And they say, oh, have you been to Old Lyme, Connecticut? People seem to think you can only catch it in America. But it's all over. It's all over the European Union, and it's quite common. I think there's a big problem with under recognition of Lyme disease. And if you don't treat Lyme disease, you get all these symptoms similar to ME. You get brain fog, you get concentration problems, you get easy crashing, you get palpitations, you get POTS, you got all these kind of symptoms. And if you do brain scans on people who've got Lyme disease, you see abnormalities in the brain. You see what they call hyperperfusion defects in the brain. If you do brain scans on people with long COVID, you see the same kind of abnormalities. So there's, so lots of people are missed with Lyme disease. And even if you treat people with Lyme disease, 20% of them don't recover. And then, they're diagnosed with, chronic fatigue syndrome. They're diagnosed with fibromyalgia. They're diagnosed with ME. So, there's a lot of similarities in the symptoms, in my opinion, of chronic Lyme. They're all triggered, in my opinion, by infection. ME was classically recognized as being Epstein-Barr virus. Long time ago, some people would get influenza, and they'd never recover. They'd have chronic fatigue after their flu. We're now seeing about 20% of people that get COVID never recover. They get long COVID. So it's the virus that causes the damage to the brain, the immune system, everything. And then you probably are getting reactivation of other viruses. Everybody has viruses inside their body. Most people, their immune system handles it and they get along. But when something comes along, I think like Lyme disease, which damages your immune system, when something comes along like COVID that damages your immune system, you can get reactivation of all these viruses in your body. And it can cause all the brain symptoms, the joint symptoms, the POTS symptoms. So that's kind of my basic synopsis of it. There's a huge under-recognition of Lyme disease in the UK and Ireland. And you've probably gone through this yourself. The patients that don't get diagnosed go to see the doctors many times, all your tests are fine, and next thing you know, it's a psychological problem. In fact, if you mention to most doctors, I think I've got Lyme disease, they'll just shoo you off, won't want to see you again. So that's my experience. I established a foundation in Scotland, the Lyme Resource Centre, and the purpose of that was just to educate people on that ticks are around, that ticks carry Lyme disease, that if you catch it early, this is the important part, it's a bacterial infection, and if you treat it with antibiotics, you can cure people. But if it takes you a year or two to diagnose them, the damage done, and a lot of people never recover, as opposed to a lot of the viral diseases. Once you've got Epstein-Barr virus, you can't eliminate that virus. It's in your body for life. The best thing you can do is repair the immune system to keep it in check. But there's potential if Lyme is better diagnosed, and treated early, that people can recover and stay well. But I've seen thousands of people now that have never recovered, and I see them years and years later with Lyme disease, and they've gone to see 10, 20 different doctors. So I'll stop now and kind of see if you understand what I'm saying and see if you get any questions.
Quick disclaimer before I start yapping. I am not a medical doctor. Any information I share is for informational purposes only.
Absolutely. I think you articulated that fantastically. Not surprised, it's your background. Just to elaborate on the psycholization and, the biopsychosocial school of thought that sort of plagues a lot of illnesses that don't have the agreed biomarker. I personally was quite fortunate, and this is going to sound extraordinarily contradictory, but I was quite fortunate that when I was hospitalized with the severe acute viral infection, which was Epstein-Barr, it didn't clear from my plasma, which is where a virus would usually clear first. Obviously, as I always say, it can persist in tissues, but it didn't clear, and that was really unusual. So it was difficult, if not implausible, for a doctor to try and psychologize what I was going through a year or so later when it still hadn't cleared. But something that was coexisting with that infection from the beginning is I suffered with chronic UTIs. Now, anyone who knows enough about urinary tract infections, especially chronic ones, will know the fact the NHS tests are not fit for purpose. Potentially similar to Lyme, we'll talk about the test for Lyme, imminently. But they're not fit for purpose. And unfortunately, that meant that I would sometimes test with very severe chronic pain and symptoms in my bladder, and it would come back that I didn't have an infection when I did. I was pretty adamant that I did, but that's when more of the psycholization came in with, being told I might be in a self-perpetuating cycle of going to the toilet frequently, and should I be training my bladder, etc., etc. And just to sort of try to say this as concisely as possible, I more recently found a private testing laboratory that traces the DNA of the bacteria, which is much more accurate than what the NHS use. And lo and behold, we found a chronic infection in my urine and in my vagina, bacterial, that was treated initially with azithromycin. Then I went on an extra week of doxycycline. Thank goodness it was cleared. Now, I did note that both of those antibiotics also, from what I've read, potentially treat Lyme. So it just got me thinking about Lyme again. The two antibiotics that I've been on for this other bacterial infection, it made me think, well, how do I know that I don't have Lyme? And for me and many others, how would you find out if you did have Lyme, if the NHS tests similar to the UTI testing aren't fit for purpose? How do you then go about saying, okay, I've got this, and or can it be treated?
So the testing for Lyme disease is like you said, it's imperfect. It's best 50-50, So if you get a tick bite, you pull it off, you get a bullseye rash, you get a flu-like illness, you've got Lyme disease, it's classic. But if you go to get the testing done, it's only positive 50% of the time. Sometimes your immune system doesn't make an antibody response. If your immune system isn't that good, you don't make an antibody. And then there's kind of a theoretical belief that the tick actually releases proteins that block the humans making an antibody response. So at best, the testing is 50-50. And this is really the challenge. So you don't kind of hang your hat on an antibody test, but people do. They say, oh, your Lyme test is negative, therefore you didn't have Lyme. And that really is the challenge. Some people have a classic story that I went to the Scottish Highlands, in the summer, I got a flu-like illness, and then I got symptoms all over my body. GPs will say, oh, we'll do a Lyme test. And if your Lyme test is negative, they'll say, you just had the summer flu. The flu is a winter virus, it isn't around in the summer. So the testing is imperfect. The other thing that we've kind of realized is that it's not just always Lyme disease. There's other infections similar to Lyme. So ticks carry other bacteria besides Lyme. They carry Anaplasma, Rickettsia, Babesia, maybe Bartonella. And those are bacteria that I always say they don't kill you quickly. They can go into your system and they can go dormant, or they can go subclinical, and they can stay with you for years and years, I think. There's other infections. For example, you've heard of people getting sexually transmitted, chlamydia trachomatis. There's another bacteria called chlamydia pneumonia. There's other bacteria called mycoplasma pneumonia. These are bacteria that get into your body and they can go subclinical, and they can just they go into the cells and they just lie in there and they slowly, cause problems. For example, about 10% of my patients with Lyme disease, they have urinary symptoms. They have bladder inflammation. And similarly, you do a screen for urinary tract infections, and there's no bacteria there, there's no white cells there, but there's inflammation there. And who knows, the bacteria might be in the wall of the lining of the bladder causing inflammation and not being picked up by the system. And I've actually seen men with classic Lyme disease, they got the bullseye rash, they got sick, 26-year-old men, joint pain all over, and they start bedwetting. They're just losing control of their bladder, because they had Lyme disease. And there's other bacteria similar to that. So those antibiotics that you received, doxycycline and azithromycin, they're covering mycoplasma, they're covering chlamydia. There's another chlamydia that's not sexually transmitted called chlamydia pneumonia. They're covering Lyme disease. They're covering Anaplasma rickettsia. They're covering also Bartonella. They're covering a lot of different bacteria that we think people can be infected with. And then even without treatment, those bacteria just go what I call subclinical. They go into, they get into your body and they start causing trouble, but low-grade trouble. And then sometimes it takes another infection to come along, like COVID, to knock down your immune system. And then Epstein-Barr flares up when you get COVID, long COVID. CMV flares up. People get herpes outbreaks. People get zoster outbreaks. And we think also that some of these bacterial infections that are subclinical can start becoming active. The challenge is most of these bacterial infections are not in the bloodstream, they're in the tissues. There's not good PCRs, to prove that they're there. And a lot of these bacteria evade immune surveillance because they're in the tissues, they're not in the bloodstream. So you don't even make an antibody against them. So they're really hard to diagnose. This is the challenge.
How do you go about diagnosing them then? Is that what you do at your center?
Unfortunately, there isn't good diagnostics. Now, there are foreign laboratories that are now doing, that have developed some PCR testing. There's a laboratory in Germany called Armin that does a series of antibody tests that are probably better than the UK tests. Rather than being 50-50, they're 80%. But antibody tests depend upon a good immune system. And like I said, look, I saw a patient who's HIV infected who had a negative HIV antibody test because there was something wrong with their immune system. Their PCR was positive for HIV, We see people all the time who don't mount an antibody response for many different infections, even occasionally, including HIV. So the challenge is I use all the tests I possibly can. I treat people based on my clinical suspicion, based on their history. I've got all these people who are forestry workers in the UK, and they get bit by ticks all the time. And they've got all these symptoms, but their Lyme test is negative. It's probably Lyme disease. So I put them on a trial of treatment. Until you have a PCR test that's 100% sensitive, you have to use your clinical judgment. And when I put people on treatment, when I highly suspect Lyme or an infection or similar to Lyme, about 70% of them improve or go back to normal. So it's a clinical decision. and I put them on antibiotics or combination antibiotics. And it's the best trial at this stage because statistically, not bad. If you've been sick for 2 or 3 years and you've got a 60-70% improving on a couple of months of combination antibiotics and some supplements to repair the immune system and supplements to help with the inflammation, 2/3 of people improve. The 1/3 that don't improve, you say, stop the antibiotics. It's not working.
I don't want, especially in such a fragile state, to take any medication that I don't need. But while we don't have an agreed biomarker for so many things, clinical judgment is crucial. And with a statistic like 70%-ish, I'd be inclined to explore that particular avenue. I'm in my 6th year. And for me personally, I know I'm laid down right now, I'm a bit crashy. But I do get better days and I have improved. But I was kind of hoping after these antibiotics, I would have a bigger energy envelope and I would continue getting better and better. That hasn't quite happened yet, unfortunately. And it just got me thinking, what else is going on? And are there ways in which I could possibly approach treating them? Hence why I thought about Lyme. Ironically, another test has come back and I do have another bacteria that we're treating with amoxicillin.
Interjection. I've learned that some patients who clear an infection like I had in my bladder don't always get the benefit immediately. So I do still have much reason to hold on to hope for improvement here. Plus, since filming this, I can report less pain. Stay tuned to find out more about exactly where I go to test for my bladder infections. Or head straight to Digital Microbiology. www.digital-microbiology.com.
It's really interesting that you said the bladder for some of your patients with Lyme has the inflammation and is sort of obviously clinically you've noticed that. Can you tell me a little bit more about that? That's just out of my own curiosity because I've obviously my own symptoms.
It's when you get a tick bite, the bacteria inoculates bacteria into the skin, it gets into the bloodstream. And where does the bloodstream go? I always teach people the bloodstream goes to the brain, the bloodstream goes to the joints, the bloodstream goes to the nerves, the bloodstream goes to the gut, the bloodstream goes to the bladder. It goes to it goes to the heart, it goes to the sympathetic, parasympathetic system, it goes to the nervous system. So it goes everywhere, and same thing with COVID, long COVID. The virus goes everywhere through your bloodstream, to your brain, to the muscles, to the joints, to the nerves. It goes to the gut for sure. I don't know if COVID goes to the bladder actually, but I'm saying that's not as much of a complaint of my long COVID patients, but definitely my Lyme patients. And the trouble is, like I said, you can have urinary symptoms, but when you go to a GP with urinary symptoms, they're looking for bacteria in the urine, they're looking for white cells in the urine, and they're not always there. So, but my observation is when I treat people for suspected Lyme, often their intestinal symptoms improve and their urinary symptoms improve. And I put people on a combination of antibiotics. And you're always nervous if somebody's got a bad gut. You're sometimes worried about putting them on antibiotics, but very often their gut improves. So similar to the Helicobacter pylori story. Helicobacter is the ulcer. Caused by a bacteria, and if you had an ulcer and you started antibiotics, you think your ulcer would become worse. But when you treat people for Helicobacter pylori with 3 antibiotics for 2 weeks, their ulcers go away.
Before the discovery of Helicobacter pylori in 1982, doctors believed that lifestyle factors were the primary cause of peptic ulcers. These factors included a high diet in spicy foods, stress, and an inability to manage stress.
Since we've got poor diagnostics for all these things, my approach is I accept any lab test that people have that can be helpful. The NHS kind of says we don't accept any foreign laboratories. They're not accredited. Well, this is a bunch of nonsense. Every foreign laboratory is accredited. They've got the German laboratory accreditation is called DAX accreditation, and the laboratory in Germany also has called ACP, American Clinical Pathology Accreditation. They've got international accreditation, and if you do a battery of tests for Lyme, Bartonella, other infections from Germany, and you take it to a GP or you take it to a specialist in the UK, they say, oh, we don't accept these foreign tests. They're not accredited. They are accredited, and patients pay a lot of money for these tests. So I accept any test that is available. But I also, base it on the history. If I have a suspicion of Lyme disease based on their environmental exposure, based on their clinical manifestations, and ultimately it's a trial of treatment and for a couple of months. But I don't see everybody, like I said, who has chronic fatigue syndrome. I don't see everybody that has fibromyalgia, because there's only a subset of them that have Lyme disease or a bacterial co-infection. But the good news is it's potentially reversible with antibiotics, because antibiotics kill bacteria if you treat them properly. The UK guidelines are Irish guidelines are treat 2 weeks of doxycycline. But the issue is, if you've got Lyme for 2 years, the bacteria's in the tissues, it's not in the bloodstream. The bacteria's in biofilm. It's in cystic forms. So the antibiotics don't penetrate very well into the tissues. And that's one of the advantage of azithromycin, for example. Azithromycin is one of those bacterias that get into the cells, get into the tissues, get into the biofilm.
Sorry, you mean azithromycin is one of the antibiotics that gets into that?
It's one of the good antibiotics. There's another antibiotic I use called rifampicin. Rifampicin is another antibiotic that gets into every tissue in the body. Amoxicillin doesn't penetrate as well into the tissues. It's good for the bloodstream infections, but it's not as good for the biofilm. So I tend, as an infectious disease doctor, I tend to use different antibiotics, and then sometimes antibiotics for a longer period of time. It takes longer to get people better,
And how long would you, or do you treat people on certain antibiotics for such infections? Like how many weeks, and where's your cutoff point?
I usually treat them for a period of 2 to 4 months before making a decision as to whether they're getting better or not, because sometimes they get worse before they get better. But after 4 months, you're either 2/3 that are improving, or you're the 1/3 that aren't improving at all. And that 1/3, all the antibiotics in the world are not going to help people, because either there's no bacterial infection there, or we're not penetrating in. So I stopped the antibiotics in that group. But unfortunately, even when I treat people and they go back to see the specialists, it didn't get them better. Rheumatologists, neurologists, other, and even infectious disease doctors, that when they get better, they go, oh, this had nothing to do with the antibiotics. It was just your time to get better. There's such a, there's such a prejudice against new ideas, new science. When I see something new that somebody's doing better that I didn't improve, and I try to learn from them, but there's such a wall. Lyme is so politically charged for some reason, because it's made out to be such a rare disease, and the patients are made to be so marginalized, So it really is a huge
lot of
challenge.
it boils down to the fact that people don't like to put their hands up and admit when they're wrong about something. Thankfully, the GP and or specialist involved has responded quite quickly to the testing that I took. It was digital microbiology, and that follows the DNA of the infection. And you can't really argue with it.
Second interjection. Digital microbiology informed there is no signal in my samples for the presence of the main bacterial species associated with Lyme disease. However, as discussed in this video, it is not known how much of this particular bacteria would be expected to find its way into the urine samples, or how much of it will only be found deep in the cells of the bladder.
People are quite sensitive, that if you're not following the guidelines. Now, unfortunately, I see people with other infections, like bone infections or skin infections, and the guidelines say for a skin infection, you should treat 7 to 10 days, but sometimes you need to treat for 4 weeks. For bone and joint infection, they say treat for 6 weeks, but my colleagues, for bone and joint infections, they're treating people sometimes for 6 months. So for Lyme disease, everyone's cured with 2 weeks of doxycycline, and if they're still sick, it's post-treatment. But there is no biomarker to prove. There is no PCR. There is no antibody test to prove that they're cured. And I say, look, if I treat you with 2 weeks of doxycycline and you get better, and you stop the doxycycline and your symptoms came back, I can teach my labradoodle that, oh, the antibiotics were working. Maybe you just need a longer course. But not when it comes to Lyme disease. People are
well, I would
people have
argue
such,
that Labradoodles are probably more intelligent than a lot of these
yeah.
specialists.
Anyway, yeah.
Labradoodles are very smart. I have
Yeah, they
Labradors.
are. Yeah, yeah. I had one of those for a while. Yeah, very smart dog. But no, what I'm saying is it's just ironical, and you can't even have a discussion. It's such a politically charged area for
It is, and
Lyme
shall I tell you what
disease.
else is ironic? You're saying about the, whether or not they follow the NICE guidelines. We're still in a position with ME. The NICE guidelines changed in October 2021, and
Mm.
hospitals around, the UK and the world essentially, but talking about NICE here, they aren't implementing them. So they don't follow the NICE guidelines anyway unless
Yeah,
it suits
and,
them.
and I've seen about probably almost 2,000 people with long COVID now because I've told you there's a lot of similarities between the symptomatology of chronic Lyme. Now, long COVID I don't treat with antibiotics, but because it's a virus, it's a post-viral infection. But I use a medication called low-dose naltrexone (LDN), which
Yeah,
helps
I've
about
I've
80.
been on low dose naltrexone. I can't say it, but I've been on it. I've got some.
It helps about 80% of people. It helps with the inflammation. It helps with the immune system. I put people in a series of supplements to help with the immune system, help with the inflammation, help with the mitochondria, and then sometimes I do put people on suppressive antivirals. Valtrex, which is an antiviral, doesn't work very good against Epstein-Barr virus, but it works against the herpes viruses. It works against the shingles virus. It works against, there's a virus called HHV6, HHV8. It works against most of the herpes viruses that can be reactivating and contributing to the symptoms. And I would say about a third of people get symptomatic improving in the Valtrex. I'm not an ME doctor, okay? This is not my specialty. I'm an infectious disease doctor who got into taking care of patients with chronic illness because of Lyme, chronic Lyme. And then I started seeing all the long COVID patients because nobody else will. And unfortunately, because they're basically told there's nothing we know, there's nothing you can do, and they're telling them to push, and they're giving them you've got funny neurological symptoms. They're diagnosing them with FND, functional neurological disorder, which is a conversion disorder. It means emotions are signaling your neurological illness. That doesn't make sense to me. Not functional neurological disease. It's organic. There's something anatomical wrong with the brain. The brain's inflamed. So I disagree with an awful lot of the terminology that, same thing with rheumatologists. They talk patient hurt all over. They say you've got fibromyalgia. Then some people are happy with the diagnosis of fibromyalgia. I say, well, 5 years ago, you weren't hurting all over. What triggered you to be hurting all over? There must be a trigger for these things. And very often it's an infection, either a bacterial infection or a viral infection.
I couldn't agree more with everything that you've said. We've only got a couple of minutes left. So I think today, just because of my
Yeah,
energy levels,
yeah, that's fine.
let's leave it there. But I'd love to talk to you again.
My big vision for the future is if we could have a national center for neurorehabilitation that had the right experts, because there's so many overlaps between ME, CSF, chronic Lyme, and long COVID. We need experts with the right expertise, and it's almost like a brain injury.
My partner's a serious injury lawyer, and we've had almost the exact same conversation because obviously he deals with brain injury.
Yeah, yeah. So there's similarities. So look, I'll let you go now. And if when you're feeling better, I'm happy to meet with you again. Okay.
Absolutely. Thank you so much.
Okay.
Bye.
See you then. Bye bye. Cheerio.
There will be a part 2 to this interview / video, and I will provide an update once I've worked with Armin Labs to get me tested for anything that might be suitable. I think I'm filling out a checklist, and then I will book an appointment with Professor Jack Lambert and discuss the results. In the meantime, and this is not an ad, I am focusing on rebuilding my good bacteria with fermented foods, oral and vaginal probiotics. Patients that need a private consultation with Jack Lambert can email admin@iddoctor.eu or call +353 1 716 4530.